Good evening all to the 89th session of the Weekly Huddle. I am Anoop and joining me today is my friend and co-host Praneeth. We both are cardiologists working at Care Hospitals, Banjara Hills. Today we are talking about atrial fibrillation, and as Praveen pointed out, this is the second discussion on atrial fibrillation, and in fact if you take medications into account as well, then we have discussed three times things related to atrial fibrillation. This is so common entity in our daily practice that I think the basic principles of atrial fibrillation needs re-emphasis time and again, so that it becomes part of our reflex and we make sure that we deliver high quality care every single time. Incidentally, this case came to me just 2 days ago, and we actually were planning to do something else on this Wednesday, but because this case came to me, I thought that maybe this is another way to highlight how atrial fibrillation presents to us. So I am going to read out the case and I will ask Praneeth for his initial opinion. Today's discussion is going to be a little bit cardiology centric, so apology for that. But I think atrial fibrillation is as much a part of internal medicine or general medicine as it is for cardiology. So we'll try to keep it a little bit more generic in discussion. So the case is as follows. He's a 62-year-old male. He's non-diabetic and hypertensive. Both are well controlled on minimal medications. He was recently diagnosed with kidney stones, for which his local doctor, so he stays around 150 kilometers away from here, and the local doctor over there, he suggested that he needs surgery for this 20 millimeter renal stone that he has. So he planned a trip to Hyderabad to get surgery done. In his pre-operative evaluation, an ECG was done as a part of assessment, and that showed atrial fibrillation. Based upon that atrial fibrillation, the surgery was cancelled, and surgeon asked for him to see a cardiologist before he should proceed with surgery. Along with the ECG, some other basic pre-op assessment was done, which included a screening echocardiogram and basic lab. All I saw was hemogram and renal profile. I did not see anything else. So that was done at that time. He was shown to a local cardiologist of that hospital, I believe, and he was advised a certain list of medication, and he was also advised admission, which the patient obviously denied. That's how he came to me. So the medications that was prescribed to him by this outside cardiologist are, and I will read it out for you: long-acting metoprolol 50 milligrams once a day, digoxin 0.25 half tablet daily for 5 out of 7 days. So you skip 2 days out of a week. Amiodarone 200 milligrams once daily, injectable enoxaparin 60 milligrams subcutaneous daily, and it was mentioned for 5 days, and rosuvastatin 10 milligrams once daily, and torsemide 5 milligrams daily. I believe the enoxaparin was prescribed for 5 days because I guess the treating cardiologist intended to get him admitted to the hospital, and I'm sure his treatment decision would have changed after that. So patient came to me for further assessment. The only symptom he had was mild dyspnea on exertion, and that I believe too now he's voicing because we are asking him direct questions. There is no other symptoms, palpitations, dizziness, whatnot. He cannot really feel his atrial fibrillation. He has no other cardiac symptoms. Exam is significant for irregular pulse, and at the time of my examination his heart rate was 112, around 112. There was no any clinical exam finding of fluid overload. His ECG is suggestive of atrial fibrillation. There is no evidence of ischemia. I didn't have the echo report. He didn't bring at that time. He said that it was just a screening echo. They just wrote it on the file, and I could see it on the paper where it said echo is structurally normal. I saw his hemogram and renal profile labs. They both were normal. No other labs were available for me to review. As I said, this patient stays around 150 kilometers away, and he wants to get things done. He is a farmer by profession. As far as his renal stone is concerned, it does bother him once a while, but the pain doesn't seem to be that horrible. It comes once in a month, twice in a month, and he says that the pain is mostly manageable. So the point that I'm trying to discuss with this outpatient case is are the follows. Number one, what are the first order of business in such patients? So a patient who walks into your OPD with newly diagnosed atrial fibrillation, we don't know when it started. How do we proceed with that? What are the basic investigations we do? Bare minimum that you may say that, okay, these are the very basic that I will do in the very first visit. And then based upon that, I'll proceed further. Second question to discuss is what are the indications for hospital admission other than the very obvious atrial fibrillation with very rapid heart rate or atrial fibrillation in a person who is in heart failure. Of course, these are your obvious need for hospital admission. But other than that, are there any reasons why these patients need to be admitted? Then the treatment algorithm in terms of rate versus rhythm control, how to decide and how to go about it. And then what are the strategies for stroke prevention? Do we give injectable drugs? Should we give oral drugs? And how should we go about for stroke prevention in these cases? So Praneeth, this is an overview of atrial fibrillation, but we are talking more in terms of an outpatient or an ambulatory visit. How do you take up this case? Walk us through your thought process, and then I will ask my other attendees about how they will go about it.
Yeah, good evening, Anoop. So atrial fibrillation, one of the common arrhythmias that we deal. Now, first thing that I would look at is what is the rates associated, whether that is a rapid ventricular rate or it is a controlled ventricular rate. And second, how much is the atrial fibrillation affecting the hemodynamics of the patient. This patient seems to be having slightly elevated heart rate, probably not affecting the hemodynamics. He is walking to the hospital and it is an incidentally detected atrial fibrillation. Now, the first thing is whenever patient has atrial fibrillation, the thing that I look into is risk of stroke. And second thing, whether it is affecting his hemodynamics, as I already mentioned. So prevention of stroke is something which is important because atrial fibrillation, we all know, carries a risk of 5 times increases the risk of having stroke. So irrespective of whatever may be the strategy to manage atrial fibrillation, the main focus for me is to prevent stroke. That is where he should be receiving anticoagulations. Now, because it's an outpatient visit and there is no immediate threat for this patient, and also the availability of newer oral anticoagulants which are there, which are rapidly acting and equally quite effective, I don't see any role of injectable anticoagulants for him. I can very well start with one of the newer oral anticoagulants in the form of Rivaroxaban or Apixaban, which will take care of the thromboembolic prophylaxis for the prevention of stroke in this patient. And I would try to continue the anticoagulation at least for 4 weeks or so, depending on the persistence of atrial fibrillation in this patient. Now, talking about atrial fibrillation management per se, what do we do right away for this patient? If the patient is asymptomatic, even if the heart rates are around 120-ish, there is no need to rush and do anything, in my opinion, and do manage the rhythm issues for now. Now, what I look at is what are the chances of reverting this patient back to sinus rhythm. In this patient, understanding this is a first episode, I presume it is the new onset atrial fibrillation. Probably it is a paroxysmal atrial fibrillation in this patient. So this patient should deserve a rhythm control strategy because you always want to get them back to normal rhythm as much as you can. So I would consider this patient as a paroxysmal atrial fibrillation, and I would try to put him on a rhythm control strategy. So I would try to start him on an outpatient visit Amiodarone with a rhythm control strategy after I have given him oral anticoagulation. So we can load this patient orally with Amiodarone, and for that I would try to look at the labs, essentially liver function test and thyroid profile, and the basic labs of complete blood picture and a renal function test just to look at whether there is anything. So most important thing for starting amiodarone, I would look at liver function test and thyroid function test, making sure that they are okay, and then load the patient with amiodarone orally, probably 200 milligrams thrice daily is something which is easily tolerable. But if patient can tolerate, you can go up to 400 or 600, but most of them, they do not tolerate. But I start 200 TID. I'll ask him to review after 1 week. Take these 2 tablets and review. These are the things that I look into it. You already mentioned that there is an echo report and all. If the patient seems to be having any left atrial dilatation because of long-standing uncontrolled hypertension, or is there any other structural abnormality, I think that the possibility of reverting into sinus is less likely. But again, because this patient has normal echo report, I believe that he can be reverted back to sinus. So I would give him 200 milligrams thrice daily of amiodarone, probably 20 milligrams of Rivaroxaban, and I would ask him to review after 1 week and counsel him about the importance of the atrial fibrillation and need for regular follow-up. This is how I would approach this patient.
So, Praneeth, there are a lot of unknowns in what you mentioned, and I will start the discussion with those. And then, if anybody in the audience, if they want to pitch in, they can. I will try to engage in discussion with Praneeth only for all this, so that we have a little bit of discussion about the various thought process going on. And then we can have the same thought process discussed with the audience as well. And in the meantime, if you do have something to add, please raise your hand and put it in the comment box. So, Praneeth, here are some pointers, and you can just keep unmuting yourself or keep yourself unmuted. I'm going to ask you direct questions.
Sure.
Okay. So, amiodarone loading in a patient where the AFib onset you don't know, like in this case. In this case, you don't know when the AFib started. I know that at least for the last 3-4 days, he's in AFib because that is when he got the pre-op workup and everything done. But when it actually started, I don't know. How comfortable you are with amio loading right now? Do you need to exclude LA clot in this patient first?
Right. So for the same reason, I would try to give him anticoagulants with a intention to manage the LA clot in case if it is there. Yes, your point is well taken that the duration of atrial fibrillation is unknown, and there is a possibility that patient can have an LA clot which can embolize and can be the triggering factor for stroke if the patient has been reverted to sinus. The echo report which has been suggested seems to be okay. And again, as I said, if there are no pointers specifically looking at LA dilatation and whatnot, I would try to give the benefit of doubt to the patient, making again it a bit convenient and giving oral anticoagulants, which will take care of the clot issue. And equally, amiodarone, which orally, which we are starting, takes some time for the therapeutic levels to reach and actually produce the effect of so-called rhythm control, which we are looking. So maybe we expect the therapeutic levels to reach for quite some time, at least a week's time, till it occurs. And by that time, the oral anticoagulants has taken its effect and is taking care of the LA clot. That is my thought process behind making this step.
Okay, second question. Going by the same rule that we don't know the onset of atrial fibrillation, we also don't know when was he in sinus rhythm. So essentially, while he is a middle-aged adult, we don't know what his sinus rhythm is. How comfortable you are so-called rhythm controlling him as an outpatient basis where we don't know what the sinus node will be?
Again, because of the no previous risk factors other than hypertension and diabetes, and presuming his left atrial dimension to be normal, again saying that there is no chronic atrial fibrillation, no structural abnormalities, I presume that he had only atrial fibrillation recently, and I again presume or expect that the chances of getting him back to sinus are more because of the structurally normal heart and no previous history of any heart diseases or whatever. So hence, rhythm control is better provided you are able to achieve. Hence, I want to give the benefit of doubt of giving the rhythm control strategy to him because he is not having any hemodynamic compromise.
Okay, two more questions. Number one, are you okay with somebody just plain scribbling on a paper that echo heart structurally normal, or these are the cases where you would justify repeating an echo at your center even if a screening echo was done 2-3 days ago?
No, I would repeat an echo. I would repeat an echo and see for have a definitive echo. If someone has did an echo which I rely upon, if it is not satisfactory, I would do an echo myself and make sure that it is a structurally normal heart and then make this decision.
And just to complete for our audience, what exactly are you looking for in that echocardiogram?
Any structural abnormality in the form of any mitral regurgitations or mitral stenosis, looking at the sizes of left atrium, whether there is any dilatation, any evidence of any pulmonary hypertension, and overall LV function.
And then I have the $1 million question that comes up to you, Pranit. This patient actually came for surgery.
Huh.
How and when are you going to clear him for surgery? He's in Hyderabad. He came from outside. He actually needs his renal stone to be removed.
Right.
So tell me about surgical clearance.
For surgical clearance, I would to make it easy, because that was what the reason for his visit to the doctor. In that case, I would say I would ask this patient to get admitted. I will do a transesophageal echo for him, make sure that the clot is not there, and then I would clear him from surgery. If the echo is having structurally normal heart with no evidence of clot, then I would clear him for surgery, and then resume him or start him on anticoagulants post-surgery once his bleeding issues are resolved. Atrial fibrillation per se, I do not think should be a reason for preventing or postponing the surgery. The only risk is clot. So the reasonable estimate that I can do is to do a transesophageal to evaluate the risk of stroke, and then proceed him or clear him for surgery.
Okay, Praneeth, you can pause for moments. I will ask the rest of my attendees for their input, and I request all of you, if you have something to add, please raise your hand. I will unmute you, or you can unmute yourself. You can put your questions or thoughts in the chat box. I will give you a few minutes of my narration of all the questions that I asked Praneeth, because these are relevant questions that each one of us should be asking whenever we are dealing with atrial fibrillation in the OPT. If the onset of atrial fibrillation is not known, and if the last known sinus is not there, if we don't know when was the last sinus rhythm, then it is not possible for us to be absolutely certain that a patient does not have left atrial appendage clot. And if we cannot exclude LA clot, then it becomes very uncomfortable to go for a rhythm control strategy, because as we know, once you control the rhythm, for the first 1 month, there is very high risk of stroke in such patients. Now, excluding that LA appendage clot can be done either via a TEE or by just empirically giving them anticoagulation for some time. Various strategies are taken up by various doctors. I don't want to go into the merits of them. I'll just tell you the various strategies which are put up. One is what Praneeth said, that you start on anticoagulation and you give antiarrhythmic. You know that the antiarrhythmic will take few days to work, and at the same time, the anticoagulant will also be going on. So even if there is something, if there is a clot or whatnot, it should dissolve. If I make such a decision, I give patient at least 1 month of anticoagulant before I give them a therapeutic rhythm control. But these are different strategies that people do. Other strategy is, as Praneeth said, you do a TEE. you visually exclude that there is no LA appendage clot, and then you give them antiarrhythmic like an amiodarone or whatnot, and then take care of that. The second problem of not knowing when was the last sinus is we don't know what is the patient's sinus rate. In electrophysiology, there is this term called sinus node recovery time, where an EP guy, it looks at how long it takes for sinus node to come back to life if it has been suppressed for quite some time. It's almost like sinus node that becomes sluggish because of constant bombardment with atrial fibrillation. And now when you get rid of atrial fibrillation, whether sinus node will be the first one to wake up or whether it will be the AV node or the ventricles that will be the first to wake up. And even when it wakes up, what will be the sinus rate? These things are largely unknown in those patients whom we don't know what their last sinus rate was. And in that case, if patients are at high risk, like, elderly patient or those patients whose atrial fibrillation ventricular rates are very low, in those patients, we already suspect that they have probably some conduction disease, and their sinus node is probably not going to be as robust as what you would expect in a 50, 60-year-old otherwise healthy guy. So if you convert them to sinus rhythm, either with drug or with cardioversion, they may actually go in sinus arrest, they may go in sinus pause, they may go in sinus bradycardia. And if any of those happens at home, now that will be a far more deadly situation. So many of the times patients whom you think are at high risk for this conduction abnormality, you may actually want to keep them in the hospital to achieve a sinus rhythm so that you can see what the sinus rate comes. There are occasions where we have done cardioversion in the cath lab, ready for a temporary pacing in case if the sinus node does not recover post cardioversion. So when you don't have a last known sinus rhythm, these are the two issues that comes along. And then the issue about surgical clearance in this patient, I think this is very pertinent, because when we talk about value addition to the patient, this is what the patient wants. Patient is here for surgery. While he cares about atrial fibrillation, he wants also to get rid of his kidney stones. So how soon can we let the patient go for surgery? Because remember, if you have done a rhythm control, if you have done a cardioversion, either chemical or electrical, then these patients should be on anticoagulation for a month. That cannot be stopped, because that puts them at a very high risk of stroke. We all know that there is this electromechanical dissociation that happens immediately post cardioversion in long-standing atrial fibrillation. So if this patient does convert to sinus because of our amiodarone or because of our cardioversion, then it is our responsibility to make sure we put them on anticoagulant for at least a month. And if you put them on anticoagulation for at least a month, then I don't think as a cardiologist you can clear this patient for surgery, because no surgeon is going to operate with a full dose anticoagulant. You can probably interrupt anticoagulant for 2-3 days, putting some of the risk for stroke, but that will be a compromise. So I think there are a lot of these practical logistic issues that in an outpatient ambulatory setting we have to think about, which are not our reflex when a patient comes to emergency with atrial fibrillation, fast rate, where you know that you have got algorithms in place on how to treat such patients. So a lot of these idiosyncrasies we have to look into when we are putting treatment for this patient. So that was my brief narrative of individual components. I again request all of you to share your thoughts, and I will pick individual person for their thoughts in this case. I'll start with Praveen. Dr. Praveen, if you can hear me, could you please unmute yourself and share your thoughts about this case? How would you approach?
Good evening, everyone. Sir, with regards to this case, I would be first assessing his stroke risk and whether it is contributing to any of the symptoms, and what would be the substrate. So to evaluate this, I would be seeing the stroke risk score, that is by Chadwick score, and the symptom severity, whether you said it is only mild dyspnea. So the essence of treatment, whether it is rhythm or rate, will not be making any difference in this patient. And regarding the substrate severity, I would be repeating the echo and see for whether there is any sclerotic aortic wall as patient is already having two comorbidities, hypertension and diabetes, and would repeat his serum creatinine because he is having renal calculus and that is causing any obstructive uropathy. So if patient is having a CKD, then his chances of receiving effective anticoagulation before surgery would be a better option. So this would be my take-up, sir, regarding this case. And for the surgical clearance, again, if the patient is his heart rate is adequately controlled or not, we would be seeing. And based upon the risk of, based on the surgery, whether it is high risk or low risk surgery, postponing the surgery, whether it is an what you call emergency or elective, we can plan it off. But when we know that an event can be prevented, it is better to delay the surgery rather than taking the risk by compromising giving the anticoagulation.
Thank you, Praveen. I'll continue my discussion. Anybody else has got any comments? Dr. Harikiran, are you able to hear me? If you are, could you please share your thoughts?
Yes, sir. Hello.
Yeah, Dr. Hari, how will you go about this case?
Yes, sir. The same thing, like because it's an elective surgery, I probably wait for the anticoagulation to take place, like what we say, for 3 weeks or 4 weeks, and then later on, once the risk of stroke is reduced, or if we can ensure that the patient, if at all the anticoagulation is stopped, he has less chances of CVA. Only then he can go for surgery. Unless it is an emergency surgery, I don't think that there is emergency indication for the surgery because of the renal stones.
And would you admit this patient at this point, or would you manage him as an outpatient?
Like his shortness of breath doesn't seem to be so significant to admit him. He can be treated on a OP basis with the same enoxaparin it was advised previously. And then I can convert it to, because it is a non-valvular atrial fibrillation, I'll go for NOACs as of now, and then I'll treat him on OP basis rather than admitting him on that.
Perfect. Thank you, Dr. Hari. I'll move on. Dr. Shankar, if this patient were to come to your clinic, how would you manage this patient? I'm sure that you would like a cardiologist to see this patient, but before that, what would you do from your standpoint?
Here, good evening to all. Here, this case of a silent atrial fibrillation or asymptomatic atrial fibrillation, because incidentally it was found to be atrial fibrillation in this case for the preoperative checkup. It is also non-valvular also here because echo did not show any mitral stenosis or any mechanical prosthetic valve. So here, we don't know the duration of this atrial fibrillation. The duration is unknown. So it may be a paroxysmal episode or a persistent or a chronic atrial fibrillation. We don't know. How long he has been suffering from the atrial fibrillation, we don't know. So, but here, patient is hemodynamically stable. So the rate versus rhythm control is still a debatable issue. But here, reasonable option in this case, here is a rate control strategy. I go for a rate control strategy with the beta blocker. Then second one is anticoagulation. The risk of stroke is also essential in this case because there is a risk of stroke is there. So the NOACs or DOACs, especially Rivaroxaban 20 milligrams daily, we can start straight away after lunch. And after what I do with my way of approach. So after 4 weeks of anticoagulation, after 3 weeks of anticoagulation, if still AF is persistent, then cardioversion is appropriate. So then I go for amiodarone outpatient basis only, 400 milligrams twice daily for 2 weeks, then followed by 200 milligrams twice daily for 2 to 4 weeks, then 200 milligrams daily. So by this, I expect he will come to normal sinus rhythm. Then fourth one is treatment of the risk factors like diabetes and hypertension, if obese, dyslipidemia, and obstructive sleep apnea, hypothyroidism, or anything, they should be taken care of. And regarding clearance for the surgery, if the patient is on a long-term anticoagulation, even after cardioversion also, we continue anticoagulation for 1 month because of atrial contractile activity may not recover for several weeks, even after a restoration of normal sinus rhythm. So we'll continue anticoagulation. If the surgery is imminent, then we can go for, we can discontinue this Rivaroxaban for 5 half times. So that may be up to 70 to 84 hours. So 2 to 3-4 days we'll stop and we'll subject him for surgery elective. If any stroke is imminent in this case, if you think, then bridge therapy may be ideal. So this is my opinion. First, I go for rate control strategy along with the anticoagulation. Then after 3 weeks, I go for pharmacological cardioversion with the Amiodarone, outpatient basis only. Then if the surgery is imminent, then elective surgery, then stop for 3-4 days, and then we go for surgery. Stop for anticoagulants for 3-4 days, and we go for surgery. This is my strategy in this case.
Perfect. Thank you so much, sir. I think some of the points that you mentioned, I'll just repeat a few of them. So rate control strategy in this patient certainly is a very relevant one, where you give the human body a chance to revert back to sinus. And if they don't, then you kind of act, and that gives you a bridge to give them oral anticoagulant so that you don't have to do a TE or whatnot, because 3-4 weeks of oral anticoagulant pretty much means that you're not dealing with LA clot anymore. And after that, if it's still in atrial fibrillation, then going for a rhythm control is a very, very relevant strategy. It's just that over the time, since the days of AFFIRM trial, the whole debate of rate versus rhythm control, but as time has progressed, we as cardiologists have understood that rhythm control is a better way to go for in the long run, particularly in younger subset. So we tend to be a little bit more aggressive where we try to rhythm control early on. But giving a 1-month trial for a rate control is an absolutely relevant strategy to go by. You also mentioned about reversible causes, one of them being sleep apnea. I think that's a very reasonable thing to check in these kind of patients who have a newly diagnosed atrial fibrillation, because these risk factors are correctable. Also being aggressive in treating hypertension and diabetes and whatnot. So these are quite relevant subset, and I think that in an OP basis, in the first order of business, as what I was saying, in the first order of business, they are equally important to look for all these reversible causes or the risk factors that can be managed better. Anybody has got any thoughts or questions before I put up my own question? Praveen puts up, yes, Dr. Gauri, you have something to add?
Yeah, hi, everyone. Very good evening. I had a couple of questions to ask, and I would definitely want to probe here to the patient to understand, is this paroxysmal paroxysmal versus something which is long-standing or persistent. Physical exertion is something, he's a farm worker, is what I understand from his occupation. Is that something there which is relevant? Is he's exerting, physical exertion itself leading to something like AF? Does he have symptoms which look like hyperthyroidism? Alcohol use, lifestyle, smoking, what is contributing to this? And is it something that has been, if we probe him enough, maybe we would understand that it is more long-standing, not that, I mean, I'm completely in agreement that I would also, and I have seen it happen, not that I would do it, but I have seen it happen, that rhythm control should be the way forward. And I'm in agreement with all of that which has been said. But I would definitely want to know why, how long has this been going on, which may help us to maybe take care of other things which could be causing this, and helping this patient better. I absolutely agree with you, Dr. Anoop, that the reason why the patient has come in so far is for the surgery, and we need to do everything to understand from the surgeon, if it has to be done, then, how do we ensure that we get the patient admitted, take care of his cardiac issue. It is something that can be put, which means we have, right, and that discussion has to happen with the patient to make him understand in that. If there's any, for example, COPD, patients with COPD also come with AF. What's happening there? Right? We need to know more about this.
Okay, Gauri ma'am had a little bit of connection issue. Ma'am, we heard your thoughts, we heard your concerns, and I will just follow up on some of the things that you mentioned so that we have a little bit of continuity in what you said. So exercise, too much of exercise leading to atrial fibrillation, this is a data set that I'm not aware of. If anyone in the audience, if they could do this homework of mine where they can just look into if too much exercise is associated with atrial fibrillation, that will be a learning for us. Alcohol and smoking are associated. Alcohol particularly is associated with increased risk of atrial fibrillation episodes. And this particular patient do not smoke and do not drink alcohol. But certainly this has to be a part of every historical assessment whenever we are talking about atrial fibrillation, no doubts. Patient with hypertension, that becomes the single most important risk factor for atrial fibrillation, and that is why I was asking Praneeth whether there is a role for repeating echo. I certainly would repeat echo because many of these patients, they have LVH, they have left atrial enlargement, and all of these are surrogate to say that this atrial fibrillation is probably more frequent than what we are seeing. Whether it is permanent or not, I don't know, but certainly this may not be the very first episode. It is the first time which is detected, but it may not very well be the first episode if the guy has LVH or LA enlargement on his echocardiogram. And that is why I think knowing the details of echo is far more important rather than simply saying that LVEF is normal and valves are okay. So those are some of the pertinent findings that I think we should be looking into. Drug history, COPD, and all of these, they are also relevant. I think they come in the differential diagnosis when we are talking to a patient in an outpatient setting. Most of these become very relevant and very obvious. A patient who has a history of COPD or asthma and whatnot, if they are taking derifylin, if they are taking and all this, that becomes a part of normal history taking. That is why I think that while these are very relevant, they become more automatic. It is difficult to miss and obviously present entity. If we are writing an exam, then certainly we have to put on all of these entities. Praveen in the chat box writes ESC guideline 2020 about 4S of atrial fibrillation. This I think was promoted very heavily, and it gets the point across, the 4S of atrial fibrillation, which is stroke risk, symptom severity, then severity of AF, and severity of the substrate, which is valvular versus non-valvular. So every patient who has a newly diagnosed atrial fibrillation, these 4 aspects we should be looking at. And we pretty much have discussed all 4 in today's discussion. We have discussed stroke risk, which will be by the chat score, symptom severity, which you do it subjectively, but you can also do an EHRA score for that. And AF severity can be done either with a Holter monitoring, or you can do a periodic monitoring of the rhythm. And then substrate severity, which you can do with a routine echocardiogram along with your physical examination and whatnot. Praveen also asks, how common is getting sinus rhythm by giving rate control drugs like beta blocker? Praveen, I don't think there is any number. For atrial tachycardia, we know that beta blocker converts them in about 25% of the cases. For atrial fibrillation, we don't know. Now, we do have to understand that atrial fibrillations mostly are paroxysmal. So you may give beta blocker, but atrial fibrillation could have reverted anyway. So we really don't know if we can put it on beta blocker that the drug caused the cardioversion. But if I have to give a number, I'll say probably about 20% or so. Another question that you put in, is there a chance of getting atrial cardiomyopathy? Absolutely yes. In fact, in the last decade or so, we have learned a lot about atrial myopathy in patients who have got long-standing atrial fibrillation. They have been conclusively shown by cardiac MRI investigation. In fact, Salt Lake City, Utah is one of the pioneers in doing this kind of assessment of left atriopathy or atriopathy as a general in this atrial fibrillation patients. So I would suggest you to look at the publications and the details of the University of Salt Lake City, University of Utah at Salt Lake City. These guys have done some very, very good work in this scenario. Sapna asks, ecosprin, clopidogrel, acetrom or warfarin need to be stopped 5 to 7 days prior to surgery based upon high risk, but Rivaroxaban, Apixaban stopped 24 hours is enough. Sapna, you are absolutely correct. I wouldn't say 24 hours, I say 48 hours. These drugs, they need to be stopped for about 48 hours in elective surgery. But remember that within 24 hours, 50% of their effect is gone. So when we are talking about bleeding risk, then after 1 day of these drugs, the effect has become less than 50%. But when we are talking about elective surgery, then they need to be stopped 2 days before, not 4 or 5 days before. And there is a rationale for that. The rationale for that is what Shankar sir mentioned, that drugs need to be stopped for 4 to 5 half-lives. When you look at Apixaban, their half-life is around 6 to 8 hours. So when this drug is given twice daily, if you stop them for 2 days, effectively 4 doses have been skipped, and that puts them at a very low risk of bleeding. Rivaroxaban, while it's a once-a-day drug, the half-life of Rivaroxaban is actually short. The half-life is only 9-10 hours. It's not 24 hours. So even if you stop Rivaroxaban for 2 days, while it's a once-a-day drug, by stopping it for 2 days, you are bringing their 4 half-lives or 5 half-lives down. So that is why stopping them for 2 days is good enough. But you are right, ecosprin, clopidogrel and all these needs to be stopped for 5 days before any elective surgery. Hyperthyroidism, Dr. Gauri mentioned, that is absolutely relevant. We did mention that all of these patients should be tested for hyperthyroidism for atrial fibrillation. Praneeth, you have something to add?
Yeah, a question basically. Now that few of my colleagues have kind of agreed to or have proposed the rate control strategy, like I'm trying to understand the practical situation of, say, this patient, we have started him on metoprolol and he's right now atrial fibrillation with a controlled rate of, say, somewhere between 60 to 70. Now, and 1 month has passed. We given him oral anticoagulants and he is still in atrial fibrillation with a controlled ventricular rate. And now if we have decided to do rhythm control, how would we approach? By the Shankar sir's idea of giving amiodarone or doing electrical cardioversion. Electrical cardioversion makes it easy because you are monitoring. But if we are doing so-called pharmacological cardioversion, what is the risk of the same thing of sinus node dysfunction or significant bradycardia? The point that you mentioned about delay in sinus node recovery. How comfortable are we giving amio and beta blocker, or if you are adding if you're adding amio, do we reduce or stop the beta blocker before we attempt the pharmacological cardioversion?
Chandramukhi ma'am, you have something to add?
Good evening, Anoop. Sorry, I joined just now. I'm very late today.
It's just a generic discussion on atrial fibrillation. If you have anything to add about outpatient management, please either type in or you can speak whenever you want to. Praneeth, your point is well taken. This is one of the problems whenever we are trying to achieve rhythm control as an outpatient basis. Whether you do it on day 1, whether you do it on day 30, that concern always remains. And the concern becomes even more when you have already loaded them with a high dose of beta blockers, because now you are actually suppressing the sinus activity as well as the AV node activity. So reducing beta blocker a little bit actually makes sense when you are going for a rhythm control, because now why to give a rate control drug when you are actually going for a rhythm control? So reducing beta blocker dose actually makes sense. But the original concern of what the sinus node will do once you achieve rhythm control, that remains, whether it's day 1 or day 30. And that is where the risk-based assessment, like in this case, probably the risk is not that much. But if you have a, let's say, 75-year-old guy who already has a AV node disease, who already has a QRS that is 150 and 120 millisecond, so you know they already have conduction system disorders, and there is a very good chance their sinus node recovery time is going to be prolonged. So in those patients, if you have to achieve cardioversion for the first time, it may be quite challenging. In patient like the one that I had this time, it may not be that challenging, but still a little bit of uncertainty remains. And truly speaking, that is the reason why I initially was saying that maybe first time when we are doing rhythm control, maybe a witnessed rhythm control is a better strategy than something at home. Now, once a while, we get those patients who you know are paroxysmal atrial fibrillation, who go in and out of sinus versus AFib and whatnot. In those patients, because you know what their sinus node does, even if they are in atrial fibrillation in OPD, you can very comfortably give them rhythm control agent, because you know that when they will go into sinus at home, their rhythm, their rate will most likely be the same as what it was previously, unless you have drowned them with heavy dose of beta blockers and whatnot. So that is a very practical consideration, and I think in OPD we need to think about it before we make decisions. Another point that I wanted to bring, and it's 7:52, so we'll have to start winding up as well. Just a few things that I will share my thoughts, and then Praneeth and anybody can please pitch into that in whatever you think. We did discuss about amiodarone loading. Now, for all of us listening today, the amiodarone loading dose, there are various permutation combinations that we see people talking about. The overall amio loading that a person needs for rhythm control is somewhere between 5 to 10 grams. In US, where I was getting trained, we had a standard protocol that every person needs to be loaded with 10 grams of amiodarone before we call it that the patient has failed amiodarone. In India, my EP colleagues tell me that because our population is a little bit more sensitive to amiodarone, a 5-6 grams of loading is good enough. I don't know if there is any science behind it, but I do honor the local experience that people have. So I try to load somewhere between 5 to 10 grams. So it's like 7-8 grams of loading is what is required. And that you can achieve with 200 milligrams 3 times daily or 400 milligrams twice daily, both of which has been discussed today. The other point that I wanted to highlight was in this patient's prescription, he is getting digoxin and amiodarone. Now, I want to highlight this very, very clearly. Digoxin is a rate control agent. It's a pure rate control agent. Beta blocker has got multiple properties, but digoxin is a rate control agent. Amiodarone is a rhythm control agent. When a patient is on digoxin and amiodarone both, then as a cardiologist, I get confused that what is the strategy? Are we going for a rate controlled strategy or are we going for a rhythm controlled strategy? In my opinion, giving both these drugs at the same time for the long-term result, for the long-term management, probably does not make sense, because those two are two completely different strategy. You are actually causing an AV node block, or you are slowing the AV node while you are trying to achieve rhythm control. So in these patients, when they do convert to sinus, you may actually land up with serious problem. So digoxin and amiodarone probably do not go together. And in the same way, if this patient, let's say we continue as it is and later on we decide to go for rhythm control, and if we have to bring this patient for an electrical cardioversion or DC cardioversion, then there is always a sense of discomfort amongst cardiologists who is trying to cardiovert a patient with atrial fibrillation who is on large doses of digoxin. Because as you know that digoxin can be pro-arrhythmic, particularly if the doses are a little bit high, and you won't know because you are not doing dig level in the serum. So in these patients, sometimes they can go into refractory arrhythmia that even your cardioversion may not be able to get you out of it. So that is one of the reasons why giving digoxin in a patient whom you are aiming for a rhythm control strategy may not necessarily be the best idea. And then the last question, which is open for discussion, is do you do ischemia workup in these patients? This is something that nobody has brought in so far. A newly diagnosed atrial fibrillation, does it call for ischemia workup? And all of these, I think the answer may or may not be there, but it is unfair to not think about it. We certainly have to think about it. Whether we do ischemia workup or not, that's a different thing, but it definitely deserves a brief thought. So those were some of the pointers that I was writing as the discussion was going on. I'm inviting any thoughts, and as you gather your thoughts for today's discussion, I will invite Somaraju sir for his opinion about what we are discussing today.
Thank you, Anoop. I agree with some of the things already mentioned. The last issue that you mentioned, digoxin, in the absence of valve disease, in the absence of heart failure, should never be given together with amiodarone for rate control. Because amiodarone is not arrhythmogenic, but that's not the right combination at all. That should not be given. Having said that, number one, the indication for surgery, I will take another opinion whether the surgery is needed or not for this kidney stone. That's number one. Number two, rate control is fundamental to begin with. There should not be amiodarone as a first choice. There should be either a beta blocker or a calcium channel blocker. Then anticoagulate, and then surface echocardiogram, chest echocardiogram is never enough to rule out anything related to left atrial thrombus, etc. And when somebody says somebody is in atrial fibrillation, no mention of atrial enlargement, even in the absence of any heart disease, structural heart disease, patient with atrial fibrillation will have atria dilated. So if that is not mentioned and is considered reported as normal, I agree with you that you will want to do the echocardiogram again and recheck on the structural heart disease or LVH, etc., thrombus, etc. In the absence of transesophageal echocardiogram, left atrial thrombus is never ruled out. And to try to convert him to sinus rhythm, that should be the later part of this patient management. And then it should be patient-related factors and patient say counseling, and whether he wants it or doesn't want it, or whether you think that medically is indicated or not indicated. Then other thing I just want us to realize is amiodarone, when you use it for rhythm control, initial loading dose or even later oral doses you give, it never should be taken into for granted that amiodarone was not helpful. It acts very late, and it may still convert when it's giving for a longer period of time. But anyway, I leave it at that. And any other issues that you want to ask, you can ask. And in the absence of when the ventricular rates are high, it's unlikely that there is any sinus node disease, less likely.
Sir, I just have one question for you. In your opinion, in these kind of patients who are so-called newly diagnosed or newly identified atrial fibrillation, what do you consider a good rate control, resting as well as exertion? In your opinion, like a 60-year-old, otherwise random healthy person, in your opinion, what is a good rate control?
Generally, in the presence of normal LV function, and most of these patients, if you carefully look at, they have long-standing hypertension, left ventricular hypertrophy. LV function is normal. I would start with beta blocker or diltiazem, and or even go for a combination as needed. And that's the way I start with.
And sir, your threshold of doing ischemia workup in these patients, is atrial fibrillation alone enough to trigger ischemia workup?
This patient is 62 years, as you said, you know?
Yes, 62, diabetic, hypertensive.
In the absence of atrial fibrillation, he needs
Right. Point taken, sir. Point absolutely taken. I'm reading some of the comments which is there in the chat box. Praveen shared one article about mechanism of AF in athletes. I will look into this article. Thank you, Praveen. He also mentions that desoxygen concentration is increased when combined with amiodarone. It does, and you know, it is just.
I just want to add here.
Yes, sir.
There was an issue raised about exercise and atrial fibrillation.
Yes, sir.
We are aware of endurance exercise or strenuous exertion or endurance exercise has the negative components, even in sudden cardiac death. It's not just atrial fibrillation alone. No, it's not good for overall body and even cardiovascular system. And it doesn't have to be highlighted too much.
Point taken, sir. Praveen also mentions in calcium channel blocker how to choose verapamil diltiazem in this patient when ischemia is not ruled out. Praveen, truly speaking, I don't think we are using verapamil as the first drug of choice anyway. And using diltiazem versus a beta blocker, if LV is okay, really, I don't think that that is too much of a problem. In fact, one would argue that diltiazem actually may have some vasodilatory property as well. But I don't think that will be a problem. I don't think we are using verapamil as the first drug of choice. So anyway, Shankar sir, you have something to add? You are unmuted.
Regarding the exercise, the physical inactivity or sedentary lifestyle on the one side and strenuous exercise on the other side. So it has got the exercise has got the J-shaped relation, J-shaped curve. So physical inactivity on one side and the strenuous exercise on the other side. And that's why we advise a moderate exercise, and especially yoga has got a very good effect in controlling atrial fibrillation. There are a lot of literature regarding this yoga and atrial fibrillation.
Thank you so much, sir. And just piling on the same thought process, there are various established triggers of atrial fibrillation as common as tea and coffee and whatnot. So while anything in moderation is probably okay, but in our history, we should also be looking at if any of these are consumed at higher than what you would call reasonable by a person, and those things also need to be addressed. If anybody has got any other thoughts, they can share with us. And while you do so, I will tell you what I did with this patient. So I asked the patient about the urgency of this surgery. I asked him about how bad are his symptoms. And as Somaraju sir pointed out, I asked him how important is this surgery from the clinical standpoint. And with talking to him and then looking at his clinical notes, we both kind of concurred that surgery is something that can very well wait and may not possibly even be needed in the future, that can be revisited. My idea was that if surgery is imminent, if this patient has to go for surgery, then I will put him on beta blocker therapy only, try to get his heart rate down to below 100 resting, and 120 or 25 with mild exertion. That to me would be what I would consider as a reasonable heart rate control. And if his echocardiogram and all the evaluation that we talked about, if all of that would come out reasonable, I would tell him to go for surgery. I wouldn't stop him from going for surgery if I achieve a reasonable rate control. In this case, though, we decided that surgery is something that can wait. And I asked him that if I can make him wait for a month or two, will that be a problem? And he said the pain I can manage, that's not that big of a problem. So when I had that as an option, I actually chose a rhythm control strategy on him. I asked him to go for a TE cardioversion, and the reason why I chose a TE cardioversion is because he's an outstation patient. I didn't want to give him a drug and let him go outside of my radar and not know what is going on. So I actually advised him to get into the hospital, where we start him on anticoagulation, do a TEE, and once we exclude LA thrombus, we do a cardioversion, achieve sinus rhythm, make sure that his sinus rate is okay, and then put him on a rhythm control strategy for a short term, like an amiodarone or something, which he can take once we have achieved sinus rhythm, so that he should not revert back into atrial fibrillation, at least for the next few months that we are looking at. And I would put him on anticoagulation, I would send him home and bring him back after a month, where I would assess how is he doing, and also I would assess the need for surgery at that time. Because at that time, if he does have to go for surgery, it will be very easy for me to just stop anticoagulant, because he already has finished 1 month. His risk of stroke has come down quite dramatically. I can stop his anticoagulant, send him to surgery in a sinus rhythm with amiodarone loaded, which will put him at a very low risk of perioperative atrial fibrillation recurrence, and he should be able to pass any kind of surgery with flying colors. So that is what I planned on him. This was my plan on him 2 days back, and he still has not made up his mind whether he wants to get TE cardioversion, because he got a little bit concerned about this whole shock thing. But that was my plan on him, a rate control strategy if surgery was imminent, versus a DC cardioversion rhythm control strategy if surgery could be delayed, and DC cardioversion versus chemical, because he is out of my radar. I want to make sure I see sinus rhythm, I see what rate he is on before I let him go. That was my strategy on him. And of course, I asked him to get all the evaluation done except sleep study, because sleep study is something which I thought could wait once we do all of these things. So with that, I will like to conclude. If there is any other questions or comments, maybe we can take 1 or 2 more. I will ask Praneeth to give his closing comments about today's discussion. Praneeth, please go ahead.
Yeah, no. So fairly common scenario. I think no matter how many times we discuss atrial fibrillation, there is always something new that you learn. And as you brought up the case today, it always makes you pause for some time whenever you have to make some decision. There are definitely these uncertainties, and there is no clear-cut answer. You always have to make an individual judgment based on the pros and cons. Take the patient into confidence, I believe. And points well taken about assessing the risk of stroke. And oral anticoagulation probably is something which everybody agreed. And regarding the strategy, as per the discussion, rate control seems to be a reasonable, safe option, at least in the initial assessment or initial treatment. And once you are okay, you have adequately anticoagulated, probably switch over to rhythm control, always keeping the patient in the closed loop and follow up. And then in the decision of surgery, always discussing with surgeon about the urgency, and equally trying to buy some time where all these so-called management can be done, where surgery can be safe, effective without any complications. So I think the so-called team discussion where plays a role again here, and where equally when patient is involved in the decision making, life becomes easy. A very valid discussion that we have today.
Thank you, Praneeth, for summarizing this. Thank you all of you for attending today's session on atrial fibrillation. This is actually very, very common. Two things that I will quickly add before I close it off. Number one, whenever you think of stroke prevention in atrial fibrillation, we have got vitamin K antagonist, we have got newer anticoagulants, but we also should think of device interventions like LA appendage closure and whatnot in those patients who are considered high bleeding risk. Rather than simply just stopping their anticoagulant, it may be a better idea to do a device therapy. That is one. And second, last year there was this data set about using NOACs in bioprosthetic valve, even in mitral position. So if you have if you had a bioprosthetic valve in mitral position up until now, the only anticoagulant which was recommended was vitamin K antagonist. But now if you have a bioprosthetic valve in the mitral position, then you can do a novel anticoagulant for these patients. It just makes life a little bit easy. So these are two of the newer developments in the field of atrial fibrillation. Dr. Bipin writes that let's do a session on GDM and hypothyroidism. Dr. Bipin, point taken. We will work on this in the future. We will do that. And if any one of you do have a topic which you think we should include in our future sessions, please feel free to put it on our WhatsApp group. We'll try to include in our session. Thank you all for your time and attention. We will see you again next Wednesday. Have a good week ahead. Take care, guys.